Hi there, thanks for joining us for what I hope is going to be a useful webcast training session on our new major trauma triage tool. My name is Reagan. I'm a consultant in emergency medicine working in Reagan Hospital in Inverness. I'm also the clinical lead for the PIC team and an absolute enthusiast like yourselves for doing good care for major trauma patients. So I'm hopeful that what you get out of today is an overview of the what are we doing with major trauma, the how we're hoping you're going to do it, and crucially the why we think this is a worthwhile use of your time to come online with what major trauma is going to be in Scotland in the years to come. So let's talk a little bit about the why. Like yourself, I want to do the best for my major trauma patients, and I'd like my evidence to be up to date. I'd like what we do to be benchmarked to what's happening in the rest of the Western world. And in 2012, Scotland got a little bit of a wake-up call. The Royal College of Surgeons of Edinburgh commissioned a report looking at the level, quality and homogeneity of trauma care for patients in Scotland. And it was pretty confronting. We found that our standards and our outcomes were slipping behind what equivalent nations were managing to deliver for their patients. In terms of figuring out how we can improve that, we didn't have to look too far for both evidence of benefit in other areas, in other jurisdictions, and in models and frameworks for what we might look at improving. So just to the south of us, NHS England 5-6 years ago started to implement their major trauma networks. And those didn't come out of nowhere. North America, Australasia have been gradually improving and evolving major trauma care in networked fashion for many years now. So there is an evidence base and there is bang for buck for patients in doing this in an organised fashion. Now, specifically what we see is what our patients care about. We see mortality benefit if major trauma care is networked. If it's done well, if it's channeled to the right place, if the right patient is picked up and is channeled, steered, guided and facilitated to definitive care, ideally in the first pass or very soon thereafter in their journey. What kind of improvements can you expect to see? Well, this is of the equivalent level of what you're hoping for with some of the medical interventions that have been truly life-changing in our lifetimes. So the equivalent survival rates, a 25% reduction in mortality, a 15% reduction in mortality. These are the kind of numbers that you're expecting to see with therapies like PCI for STEMIs, early antibiotics for sepsis, and yet with just an appropriate, sensible, carefully organised, networked approach to major trauma, those same mortality reductions have been achieved in other jurisdictions. So the Scottish Government has identified, I think correctly, that this is a priority for our patients in Scotland, and we're looking at changing how we do things. So, what can we change? What can we do differently, and how can we make sure we're not reinventing the wheel and we're learning from those important discoveries in other areas? Well, for a start, we can talk about on-scene patient triage. So picking the right patient. Having a trauma triage tool that identifies patients at their point of injury as being major trauma positive. And then designing a system and a service across our hospitals where that patient, once identified, goes to the right place, ideally the first time. And if not the first time, we're already figured out as someone who would be benefiting from major trauma centre care and is heading in that direction throughout their journey. So what's a major trauma centre? Where does the benefit there come? Well, to a certain extent, major trauma centres are places of specialty, they're places of high throughput, and they're places that have systems in place where patients are early in the journey figured to be people who should be on a rehab pathway at the soonest point, patients who might have multi-system injury and disease, and so will need a multidisciplinary approach from the offset, and who ideally should be managed by trauma specialists. Now, those MTCs can't be everywhere. So in Scotland, we've got 4 hospitals that are earmarked in gradual rollout across the country for Aberdeen, Dundee, Edinburgh, and Glasgow. And those hospitals are going to be staffed and trained to deal with major trauma. Now, that comes with specialties, it comes with certain processes, but it also comes with the right patients coming to them in the appropriate fashion. So what we're asking you to do is to get those patients there. Patients who are close enough at the 45-minute mark or closer should be going direct to major trauma centres. Patients who lie out with that 45-minute travel time from scene, then we're asking you to think about going elsewhere, and ideally it should be to trauma units. A trauma unit is a hospital that still has a very up-to-date and effective response to major trauma, but isn't perhaps providing the specialty teams, surgical or interventional radiology, for instance, that the MTC could provide. Now, to a certain extent, we'd like you to have in your mind a map of your area. We want you to be thinking about that 45 minutes in relation to where you work and in relation to where you find your patients. So it's going to be different in every part of the country where you're finding your patients. But if you've got that map in your mind, if you've got the support of a tool, and you've got the support of a trauma desk, and the support of a service that's working towards the same goals as you, we're anticipating seeing just those same kind of mortality benefits for our patients. Now, currently, there are no major trauma services in Scotland, or, let's put it another way, there's major trauma services all over Scotland. There are 30 receiving hospitals. So how are we boiling that down to major trauma centres and trauma units? Well, for a start, we've got regional networks. So within the one Scottish trauma network, we have 4 networks, one in the north, one in the east, one in the southeast, and one in the west, each of them focused around a major trauma centre. In the north, Aberdeen; in the east, or in Tayside, Dundee; in the southeast, Edinburgh; and in the west, Glasgow. So these are the central loci, these are the focus, these are the hubs for those regional trauma networks. Within those regional trauma networks, however, there will be trauma units. And trauma units are similarly staffed by consultants and nursing teams who are trained and effective in the receipt of major trauma. What they don't have, and crucially what is at the MTCs, is going to be the specialist surgical care, so spinal, cardiothoracics, neuroscience, and potentially other interventions such as interventional radiology or pediatric ITU that your patient might require. What do we have currently? Well, with those 30 hospitals currently, we have a 40% secondary transfer rate for patients. So 40% of patients are not going to the definitive care location at first pass. That's definitely something we can improve. And if you cast your mind to those 60% of patients who aren't getting moved, it may be that with the coming reorganisation of transfer teams, with the coming reorganisation of the trauma tool that we're going to talk about, that a good chunk of those 60% of patients currently might be looked after in the MTC at the first pass, and hopefully get better care in that first pass. So, rationalisation, 4 major trauma centres, trauma units that feed into them, and to a certain extent a bespoke model for Scotland. Why? Because we've got a real break between rural and urban. We've got a vast geography. We've got great differences in topography, weather, patterns of injury, and in the actual loci where we have specialist services. So what the Scottish Government's asking us to do is to focus on 5 domains across major trauma. And you can see they're going all the way from public health and prevention, moving through the pre-hospital phase with its many agencies, working together, but hopefully to a new hymn sheet, keeping absolutely up to date with what's going on in other realms. So if I can, I'd like to talk us through the tool. It's not a rule, it's a guideline, it's an aid, it's a decision-making friend at scene, and it's something that means you know you're actually working in concert with the people who are going to be looking after the patient beyond their journey with you. You know that you're going to be speaking the same language as the trauma desk and other controllers, and it means that your patient's already being flagged up and fitting into the wider network of care that we're hoping to channel these patients through. So, as you can see, it's a single A4 currently. How small we're going to reduce those down to, I don't know. You can see it's brightly coloured. You can see that it's an algorithm. You can see it's a flow chart. You can see you start on one side, work your way across, hopefully to guide recommendations as to what you should do with the patient, who you might contact, and where they might go. So it's useful to you from absolutely the first moment you get it out. And to a certain extent, you don't want to be using this on every patient, but I will armour you with the fact that we are expecting you to over-triage. For major trauma care to work, to have that mortality benefit that we talked about, we have to apply this to more patients than might actually turn out to be major trauma down the line. Over-triage rates of up to 100% have been employed in other jurisdictions successfully with mortality benefit. So we are prepared for you to overcall this on your patients. We are prepared for someone to rock up to Resus absolutely major trauma positive according to the tool, and down the line turn out to have a CT entirely benign. That is what we're hoping for, because if we're hitting that over triage of trauma rate, that means we're doing the right thing. So please do use this enthusiastically, but on the flip side, this is absolutely not replacing your clinical judgment. So if something doesn't fit the tool, or it's not suiting the situation you're in, or you're finding it inflexibly not applying to the person in front of you, this is a tool. You are the clinician. Your judgment remains paramount. If the recommendations of the tool do not fit with your local environment, with your current resource, or fitting the needs of your patient, then in concert with the trauma desk and your team, you should be expecting to make a decision for that patient that is clinically absolutely the right thing to do, regardless of whether or not it fits this tool. So your clinical judgment remains paramount. But across the population, across major trauma in Scotland, if we get this tool implemented and upfront nice and early, we're going to get it right for more of the population than we are currently. So I can't encourage you enough to try and get really comfortable with it. So, who are the patients you are going to over-triage and hopefully get to the right place so that they can be cared for? Well, you can see right at the top, if you get it out now and have a look, or get it up on the screen, you can see use this tool to triage all significantly injured patients or high mechanism incident patients. And that's your initial scan. So your initial scan of the scene, your initial scan of the patient. These are things that should be pretty glaringly obvious straight out. So it's the injury you can see and gives you a wee lump in the chest. It's the scene you see and gives you a wee pause and a deep breath. These are the patients where the tool will absolutely be important to use from the earliest point you can. Now, to a certain extent, we then break it down into usable and in order of priority sections so that you can use the tool at the earliest point and also exit the tool at the earliest point. So you don't have to use the whole tool for every patient. If you find out that someone is trauma tool positive at your first question, then that person has no more decision making to take place. You've already identified major trauma that requires MTC care. So this shouldn't be cumbersome, but it should be comprehensive for some patients so that we avoid under-triaging those patients who previously perhaps we've been missing. Now I'll cast your eyes of all the primary colours there. You can see some red, you can see some blue, you can see some green. Take a look at the yellow. That yellow is the all-important patient who is dying in front of you from airway compromise. So for that patient, should the airway become compromised and cannot be managed, so it cannot be managed, an airway that you cannot either secure or maintain patency of, then consider diverting to the nearest locally designated emergency department. That is exclusively for airway management as a time-dependent, life-threatening condition. There's a reason it's the only thing that's yellow. There's a reason why it's up the top. For response category, we're asking you to do what you would always do for these patients. Leaving that aside, everyone else in the major trauma cohort, we're asking you to apply this tool to before you make that decision as to where to go or where fits in the network. So step one, assess your patient's physiology. What does that mean? That's big sick or little sick. So that's the patient who, as you can see from the guide here, they're hypotensive. So an objective measure here of less than 90 or an absent radial pulse. They're either tachypneic or bradypneic. They're not breathing enough or they're breathing too much. Or they've got a Glasgow Coma scale that's less than 14. So not just the eyes shut, but otherwise alert and responsive patient. Not just the slightly confused but eyes open and happily obeying command patient. This is less than 14. These are the patients who are already big sick. Their physiology is insulted, and you're at the scene of a trauma. That's what's done it until proven otherwise. And so immediately that patient is now major trauma tool positive. So they're geared across to the right of the screen or across to the right of your piece of paper there, and you can see that's for major trauma centre care. And we'll talk through what that might be guiding you to do in a second, because there's another category of patients who I'd like you to sort of have in your mind who are MTC positive in the first pass. And that's step two. So for the non-physiologically insulted patient, the non-big sick apparent patient, this is the big injured patient who appears to be compensating. So normal parameters, normal respiratory rates, SATs, BP, they're doing their best to convince you that they're not dying. However, you can't help but notice that a bit has been crushed, and that bit's something important like a chest or a pelvis or an entire limb. You can't help notice that they're not moving two of their limbs, and you're highly suspicious of paralysis. You can't help but notice that there is something penetrating a bit of their viscera that shouldn't be there. A knife in a tummy, a knife in a chest, a knife in a neck, or recent evidence or story thereof. So this is the person who you have physical, visible evidence of an injury of great significance. And that person is basically insulted anatomy. they've had too big an injury for you to ignore. So what are you going to do with that patient? Well, as you can see, the tool will guide you across to the right again. That is an MTC positive patient. So what's that going to result in for that patient? Either from physiology or anatomy, your tool is going to guide you. Your patient requires MTC care. How are you going to make that happen, or how are you going to see if that's possible? Well, we've got a zone, we've got a time period, we've got a travel time of 45 minutes that has been taken from, again, other spheres and evidence of improvement in other jurisdictions. That 45 minutes is the time from either the wheels turning or the rotor blades turning of whatever platform is conveying your patient. So from when your patient is good to go to when they will arrive at their destination, if that's a projected journey time of less than 45 minutes, this tool is guiding you. It's not telling you, it is guiding you that we think the best place for that patient's care in the first pass is the MTC. So Aberdeen, Dundee, Edinburgh, Glasgow, our 4 MTCs in Scotland are the place you should be aiming your patient towards by whatever platform it is that they're travelling in. Now, if your patient is out with that 45 minutes, and you will know this better than anyone else, any circles or isochrones or journey times, you're going to know your own patch better than anyone else. And you're going to know the capabilities of your transport platform better than anyone else. If you are out with that 45 minutes, then what we're asking you to do is contact the trauma desk. And that trauma desk clinician, the whole point of that trauma desk clinician is for exactly these patients. So it's for the patient where ideally we'd like to get them to an MTC. Science tells us it's a good idea, but either that's too logistically difficult or it's going to be impossible in the absence of a secondary transfer further on, and we'd like to get that running as soon as possible. So contacting the trauma desk may result in another resource coming to you that wouldn't have otherwise been mobilised. It may result in a rendezvous point of a different transport vector coming to you, or it may result in a much earlier secondary retrieval for your patient who previously would have waited for a much more prolonged period of time in that first destination that they go to. So it is worth it for your patient making that phone call. It may change their destination, it may change the team looking after them, and it may shorten their overall journey time to definitive care. Now, they may advise there is no extra team, there is no extra transport vector that's coming to you, and there is no rendezvous to happen. Please go to. And that is a decision that's worthwhile paying attention to, because the trauma desk clinician has the map. They've got the capabilities of hospitals around Scotland. You will know your own local emergency hospitals. You will know potentially your own trauma units. You may well know your own MTC, but the trauma desk clinician has got the map out, and it's up to date. So again, it's worthwhile putting that to them as to where the destination for your patient is best to be. Good. So coming back from our MTC positive patients, you've made it through their physiology, you've made it through their anatomy, and you've still got no reason to be worried about this patient. Well, it's now that we want you to think again about that first thing that caused you perhaps to take out the tool. It's the mechanism of injury. But we now want you to revisit that mechanism and have a good think about whether it's something that really does predict or would be highly sensitive for occult injury. So stuff concealed from view generally, stuff that we find out about hours down the line and wish we'd thought about earlier. So the kind of mechanisms, the scales, the sort of energy exchange involved that are more likely to give your patient a bleed that you can't see, or a spinal injury that's unstable, or orthopedic injuries that would require specialist care. The ones we've got are pretty big and nasty. So fall greater than 20 feet, a high-risk vehicle accident, and here we're focusing on intrusion into the vehicle or ejection from the vehicle. Things such as rollover or other aspects have been taken out of this tool following learning from other jurisdictions. Vehicle versus pedestrian or cyclist at a set speed, i.e. more than 20 miles per hour, or a motorcycle accident at greater than 20 miles per hour. And this might actually sound quite conservative to people, and I think that's appropriate. It's right that we're trying to aim towards the high end of mechanism, because you've already done your assessment of physiology and anatomy in a regimented and scientifically mandated fashion. So we are really looking for those big mechanisms where the patient's compensating and the injury is hidden. Finally, we want you to think about special considerations. That's the title, but if it helps to translate it to the patient in front of you, I'd like you to think about the vulnerable patient, or the patient who we miss, or the patients who hide injuries somewhat better than others. So here we've got patients over 55, patients with a bleeding disorder or on anticoagulants, as approximately 100% of the Scottish population seem to be now. Isolated burns, and this is someone who might absolutely benefit from early specialist care in a specialist centre while still appearing quite well with the rest of their injuries. Any pregnant patient over 20 weeks gestation. And finally, people with a body habitus of morbid obesity, where we know that both their response to injury and their ability to conceal injury is high enough that it's worth having them in this special consideration category. So here, you're not being mandated or suggested towards NTC care, but you are absolutely being nudged in the direction of trauma unit care. So the trauma units, again, being those hospitals that are geared up to receive major trauma in the first instance, but not necessarily to provide definitive care, and may be absolutely the launching point for a secondary transfer if they can't provide specialist care or if the patient's deteriorating. So, what are you left with at the end? It's a no, 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 despite having a significant mechanism or initially appearing to have significant injuries. Your patient is trauma tool negative the whole way round, but they've definitely been involved in a trauma. So at the very bottom of the tool there, the exit point into the green is, you can see, framed by the word local. So to your local emergency hospital. Now, local emergency hospital now means something different in the Scottish Trauma Network. So it's not every hospital that's a minor injury unit, it's not every hospital even potentially that has the word emergency in the title out the front. And it's important, and I definitely recommend you doing this, to start to get fixed in your mind, where are the trauma units, where are the MTCs, where are the trauma local emergency hospitals in your patch. For the Northern Network, for instance, we have Aberdeen as our MTC, we have a single trauma unit at Raigmore in Inverness, and then our local emergency hospitals, the places where if trauma has occurred, this tool is still guiding you to take there, still guiding you not to go to a minor injury unit. It is guiding you to go to places like Elgin, Fort William, Broadford, Wick, and potentially bypassing those places where previously you might have taken someone. So you previously, with someone who's had a car accident but is not ticking any of these other boxes, you might have taken them absolutely to your local community hospital, to your local minor injury unit. This tool, a lot of its impact might actually be at that lower acuity end. These patients might get better care even though they're a long way from that severely injured or physiologically sick patient. So, that's walked us through the tool in a theoretical fashion. I'd like us to go through and do some scenarios in a second, but before we do that, I think it's really important to again highlight what are the potential benefits here for your patient. So particularly in a remote or rural location, it may be starting the identification of that patient really early on as someone for the rest of the network who we might have previously missed or previously a long time into their journey before we get things going in their care. It's possibly opening up opportunities for earlier either primary response from enhanced teams coming from elsewhere to you at the scene of the incident, or potentially mobilising an earlier secondary transfer for that patient from where you take them to where they ultimately need to be. And finally, hopefully, we're going to have the opportunity to improve this as we go along, as a network, as a country. And to do that, we have to gather data, we have to have a rigorous and scrutable data set, and to do that, the paperwork has to be good. So the record has to be there, it has to be uniform, it has to be regularly put in, and it has to be uniform across the country. So the trauma triage tool is absolutely buddied up to the EPR. So I'd like us to get into these scenarios if we can. So if you punch up on the screen, or feel free to print out a copy or just pull up a map, and we'll zone in for the start in Orkney, mainland Orkney. We're going to look at a job, a theoretical job, but all of these jobs are based around previous traumas over the last few years. So apologies to any clinicians for whom this either rings bells or brings back memories, but I think it's important that we do make these relevant, make these useful to us as clinicians. And if you're not based in Orkney just now, please do feel free to try and translate this case into something that would be relevant to you where you work. So we're on the A986, on the way or almost at Harray, and it's a two-car, it's a head-on. We've got 3 patients. So we've got 3 patients to make decisions about, at least initially, on approach to the scene. The first patient, very apparently, is self-extricated, is already complaining of some neck pain and some minor abrasions that they're pointing to. This second patient has been PLE'd, so there's a GP already on the scene, and they've said, this chap, I'm happy to say, is dead and beyond care. The third patient, and the one definitely worth thinking about from a tool point of view, GCS 11, 3 for eyes, 3 for verbal, 5 for motor, and as you're probably picking already from that description, they're agitated, they're combative. So it's already a difficult patient from a care point of view. So I'd like you to have a bit of a think about that. If you're with colleagues, have a chat about working your way through the tool and where these patients might fit in. So patient 1, you've got the mechanism, self-extricated, minor abrasions and neck pain. Patient 2, deceased. Patient 3, a reduced GCS, GCS 11, agitated and combative. No other signs of injury and no other physiological inflammation for you as yet. Okay, I hope that's been useful time figuring out, very much in your context, but trying to transplant yourself onto Orkney if you're not working there at the moment, how you might navigate the patients through the tool and what that might do to your decision making. From my own perspective, using the tool for these patients, I think one is drawn very quickly into patient 3. This is a definitely major trauma tool positive patient, and someone who, according to the tool, is major trauma centre care requiring, or would benefit from it if you can make it happen. So this is someone who, given the locus, is going to be greater than 45 minutes from the MTC, by whatever means. So it's worthwhile getting onto the trauma desk at the earliest point in this patient's journey. Not necessarily to expedite the primary retrieval of this patient, although that may be possible. You don't know till you ask, and you don't know whether primary retrieval might actually work out better for a patient until you pose that question. Or more likely, an expedited secondary retrieval of this patient for, again, potentially definitive care at the earliest point in their journey. Patient 1 gets a little bit complicated. So looking at the tool, is this someone who is deceased in the same passenger compartment? Does that frame the mechanism as one so threatening that this person requires MTC level care? If so, technically both of these patients are being steered towards the same hospital. And here's where your clinical judgment and conversation with the trauma desk, again at the earliest point, becomes gold dust. Because you can be saying, from my read of the scene, from my read of this patient, here's how I would apply the tool to this patient. And from the trauma desk perspective, they can advise you on, well, actually, if you're getting along to the Balfour, if you're getting to ARI initially, this patient might benefit from, and tailoring to the patient you see and the care that's available in concert with the trauma desk, the best solution for that patient. Okay, let's try another one. So we're going to go to a place called Dunbeath, just up the road from where I work, and I'm going to give you another RTC, if that's all right. The mechanism is, as you see, so we've got a car overturned in a ditch. There's a 63-year-old male who's trapped and described as unconscious. Someone's reported a head injury, and they're GCS 3 at first assessment. Their BP is 176 on 80. They're tachycardic, demonstrably so at 123 per minute, and mildly hypoxic, and this is on room air, or on car air. SATs of 93%. So, have a chat, look at the map, think about where the local emergency hospitals are, get a rough feel for distances, think about where the trauma unit is, think about where the MTC is, think about what might be achievable in terms of journey times for yourself in the vehicle that you're in, or in any other teams coming to or from you, and then have a think about where this patient would fit and who you might be contacting. Okay, welcome back. Again, hope that was useful. So, to my eyes, looking at this patient, looking at the tool, this person is demonstrably major trauma tool positive, and they are absolutely in that first guided across from physiological insult, major trauma centre care requiring or recommended. However, they are absolutely more than 45 minutes from the nearest major trauma centre. They are a long way from the nearest major trauma centre. So this patient who, whilst it shouldn't be delaying your on-scene care and attention to the patient, or indeed you starting to get moving, absolutely factor in here an early conversation with the trauma desk at the earliest possible point is going to be a benefit to this patient. It may assist in where they go. It may assist in how they get there. It may assist in them getting definitive care at an earlier point. Great. Okay, so we're going to bring it a little bit closer to the coast and a little bit closer to the town. So we've got a fracas has taken place of some form in the lovely seaside town of Stonehaven. There's been an alleged assault, a single stab wound to the left side of the patient's chest. Your initial numbers for this patient are GCS 15, BP of 123 on 80, pulse 99, SATs 95%. No other injuries detected, and the mechanism is exactly as it's described. So, have a look at the map, have a look at the tool, have a think about yourself on scene, who you might want to talk to, if at all, where you might want to go, or who you might want to consult, or where your options are, based on what you know of the MTC's location to use LEHs. So, my reading of this is absolutely the patient where you are supported to do exactly what should feel instinctively the right thing to do. This is a absolutely mandated, life-threatening potential injury. The mechanism itself absolutely should steer you towards MTC positive from a trauma triage tool positive patient here. So you should be pointed towards the MTC. When looking at your journey times, I'd heartily suggest that Stonehaven is well within the 45-minute drive time. So even if it's just yourself with a road vehicle, this is someone who should be pointing direct towards the MTC. And technically, because that's where the tool's guiding you to go, you don't need to contact the trauma desk for this patient. So you using the tool on the EPR is already going to flag them up to the network. They're going to the place of definitive care, so they're incredibly unlikely to need secondary transfer out. So the trauma desk isn't needing to know about these patients unless you're looking for clinical advice. And the trauma desk clinician absolutely is there to support crews at scene or indeed en route with a major trauma patient. So if this person suddenly changes or decompensates, or you're looking to have guidance on any trauma intervention, or potentially change locations, so say you were being steered towards one part of the hospital and then a change of mind to go to a different part of the hospital, trauma desk absolutely on the end of the phone, quick as you like. This one's going to be in a place called Alves, which sits on the A96, so you can see the far sort of western end of that stretch Inverness, which is a trauma unit. At the sort of eastern end there we have Elgin, which is designated as a local emergency hospital, and an incident has taken place on the A96, and it is a nasty looking RTC. So you've got a car versus a lorry. The car's overturned, which, bearing in mind, technically doesn't sit on here as a triggering piece of mechanism. However, your spider sense is tingling. There are two patients here. One is a 38-year-old female who's GCS 3 and has gurgling, very audible gurgling, obvious trismus, a locked jaw. And the second patient, whilst better than patient 1, is still themselves unwell. They've been ejected from the vehicle and have an obvious head injury. And it's yet another GCS 13 agitated patient, eyes 3, verbal 4, motor 6. So they're not making much sense. They prefer their eyes shut, and they will do what they're told, but they're wanting to do a whole bunch of other stuff that gets in the way of their care. So these are two very unwell patients. The location, I suggest, is a challenge. Their injuries are going to be a challenge, and their physiology is going to be a challenge. So take your time with this one, have a look at the tool, have a think about what you would do, who you might call, where you might go, and what might be available. Coming back to it now, this is my take on this, and I'm very keen for an informed decision to be made at scene by you, the clinician. Ideally, if needs be, in concert with the trauma desk clinician or the single point of contact of the Northern Network. But my take on this is that patient 1 clearly has an unmanageable airway. So this is an airway that needs protection and secure for everything else. Your local emergency hospital is Elgin. It is closer. That is where that patient's airway needs to be managed. And then the rest of their trauma care is going to take place both there and ideally with a secondary transfer, ideally to the MTC thereafter. And this is the patient where the earliest point at which the trauma desk can hear about them, the sooner that secondary transfer is going to be expedited in the years to come. Patient 2 is trickier because you've got the trauma unit that way, you've got the local emergency hospital that way, you've got one patient already going that way, and logistically, can you split your team? Logistically, do you have enough vehicles? Logistically, can they wait to go elsewhere? And from a patient point of view, are you happy that you've got enough of a run time, it's short enough a journey to get to the trauma unit? Now, the trauma tool would dictate, or wouldn't dictate, it would suggest that this is a patient who's going to benefit from trauma unit level care. And ideally, if all the rest of it fits, including your clinical judgment, that's where they should be going in the first instance. A single major trauma triage tool, why we're doing it, how we're doing it, and what it actually is in an operational sense, I hope we've made reasonably clear for you. This is going to be an evolving thing. It's going to be an evolving network. It's going to be an evolving triage tool as we evaluate how well it functions, both on the ground and for patients across the country. There's going to be elements where it does and doesn't work, and we're hoping to improve as we go along. Crucially, you guys remain absolutely clinical primacy of the patient in front of you. Your clinical judgment is all important. Early identification of your patients is going to make a difference here. Early communication, both to trauma desk and the receiving unit with an ATMIS pre-alert, is absolutely going to make a difference for these patients. And at the end of the day, we're going to have a better level of major trauma care across the country if we can do this as a network and do it in an organised, joined-up fashion. Thank you very much for joining us.